All right. Good morning, everyone. We'll go ahead and get started with the grand rounds today. It's really my privilege and honor to introduce Dr. Subhas today. As you all know, he's one of our colorectal surgeons. He's an outstanding clinician and an excellent colleague. I'll say personally, like anytime I have a question or a concern, he's always available to consult or to come help. And that's something that, especially the residents, as you become attendings, you'll really come to appreciate having someone who's available to help you, take on some challenging problems. Dr. Subhas completed his surgical residency at Providence Hospital in Southfield, Michigan, pretty close to where I did my residency, and his colorectal fellowship at Rutgers University in New Jersey. He's been with us at CHI as assistant professor since 2022. He has an incredibly impressive CV, 57 publications, 86 podium presentations, 34 posters, and 11 research grants. What I remember from his grand rounds last year was that he's also something of a Renaissance man. He's a private pilot and a photographer. And like I said, an excellent surgeon colleague. So I'll hand it over to Dr. Subhas to learn about C. diff infection.
Can you hear me well? Okay. So thanks, Dr. Patel, for the introduction. So I'm going to talk about C. diff infection. In my previous job in Sioux City, I used to take a lot of interest in C. diff, and I used to do stool transplants there. So I thought it would be a good topic to discuss here. It's not seen that frequently here. I would say in this place, I might have operated on 3 patients since I joined in this 3 years back. And I'm sure the ACS team might also do like 1 case every 6 months, 3 to 6 months. That would be the average. But it's important to know how to manage this case, because once in a while, these patients, when you see, they can get sick really fast and they can even die. And also there's a high morbidity associated with this condition when you do a surgical treatment for them. So it's important to know what you can do to help them. In this talk, I'll talk a little bit about C. diff and other the medical aspects, but I'll focus more on the surgical aspects. So C. diff infection, previously it was called Clostridium difficile, but the new name now is Clostridium difficile. I'll just call it C. diff. It's much easier to call it that way. It's an anaerobic gram-positive bacillus bacterium, and it can be a normal inhabitant of the colon. It can be a common cell of the colon. So it's just the presence of C. diff by itself, the bacteria by itself in the colon doesn't mean you're infected. We specifically test for toxins, and then we see if the patient is symptomatic or the person is symptomatic or not, with that to call that like a true infection going on. And we know it's transmitted by the fecal oral route. Coming to prevalence, it seems that the infection has been pretty steady. There are like numbers from 2011 and 2017, and both those years numbers show that the estimated infection rates were close to like 500,000, and the deaths were around like 20 to 30,000 in those years. And this bacteria is present in the stool for approximately like 3% of the population, but people who are in healthcare or who are exposed to healthcare facilities, we can see up to 50%. So I'm sure like if we test ourselves, probably most of them might have a C. diff in their stools. And people who are like immunocompromised, immunosuppressed, or inflammatory bowel disease patients, or with other medical comorbidities, they might have little higher chance of having C. diff in their stool. So the C. diff infection most commonly involves the colon, but for a person who has underwent a colectomy and has hand ileostomy, they too are prone to develop a C. diff infection, because now their terminal ileum starts behaving and acting more like a colon, with having the bacterial flora similar to that of a colonic flora. In the early 2000s, there was some virulent strains of C. diff seen, and it was called the 027 toxinotype strain. And at the time, there was little higher morbidity and mortality associated with it. But now we don't see any special difference with that strain, so we don't give any specific importance to that strain. And also lately, we have seen a lot of this antibiotic stewardship in place in all the institution and places, and that has played a big role in trying to bring down the incidence of C. diff infection. What are the risk factors for C. diff infection? As we know, the infection happens when somebody has taken antibiotics. And if they've taken antibiotics, this infection can manifest anytime for up to 3 months after finishing the antibiotics. And then also taking like the antibiotics for a longer duration, taking the stronger antibiotics, and the number of antibiotics taken, all those things has a role to make you more prone to develop the C. diff infection. The symptoms of C. diff infection is mainly diarrhea, and the diarrhea happens because of the response of the mucosa of the colon or the colonic lining to the bacterial toxins which are produced by by the bacteria. The most common antibiotics known to cause this is clindamycin. In fact, the first cases of C. diff infection was noted when patients were taking clindamycin. And then we also see it with the penicillin-based antibiotics and the fluoroquinolones, the ciprofloxacin, levaquin, and the cephalosporins, which are kind of penicillin-based. So historically, C. diff infection was considered to be a nosocomial infection, means an infection caused by a healthcare facility or the hospitals. But nowadays, we see that some of this infection happens at community as a community-acquired infection as well. The risk factors for somebody to get an infection is advanced age. Interestingly, female sex is a risk factor to get the infection. People who are being immunosuppressed, be it like transplant medications or cancer chemotherapy or some of those newer biologic, people with inflammatory bowel disease, and interestingly, people with medical conditions like renal failure, congestive heart failure, and liver diseases, and also diabetes. Also, people who undergo emergency hospitalization, emergency GI surgery, people are malnourished, people are on tube feeds who take the proton pump inhibitors, they are also at high risk for developing a C. diff infection. How do the patients manifest? There'll be a wide range of manifestation. The most common is diarrhea. Diarrhea is the key thing to kind of diagnose a C. diff infection to start off with. And then we need to have at least like 3 or more watery stools without any intervening constipation or formed bowel movement. So that's the kind of definition we use for C. diff infection. And patients might have these manifestations which are similar to any other colitis. So it's important that we try to diagnose that early by testing, because people with C. diff colitis or C. diff infection can turn really sick really fast, and if not intervened at an appropriate time, they can even die. The severity for C. diff infection. So it's a big spectrum. People can, with C. diff infection, can range from asymptomatic colonization to mild to severe and fulminant colitis. So asymptomatic colonization or carrier, as I said, a lot of people would be a asymptomatic carrier. I'm sure the healthcare workers would be asymptomatic carriers. So they have C. diff colonized in their colon, and they don't show any signs or symptoms of a C. diff infection. And it's very difficult to classify the severity as mild to moderate just based on the physical examination and history. We do need some laboratory tests as well to kind of help make the distinction. So C. diff infection, as I said, more than 3 loose watery stools without any intervening constipation or hard stools or formed stools. And along with that, we have patients presenting with other systemic features of abdomen pain, cramping, nausea, vomiting, loss of appetite. Mild infection is when they have the above features of a C. diff infection, along with white cell count of less than 15 and creatinine less than 1.5. And severe infection is when they have the C. diff infection with white cell count more than 15 and creatinine more than 1.5. And then we use the term fulminant or toxic infection when C. diff infection has like peritonitis or organ failure picture or a megacolon picture, or also if they're going to manifesting with features of Helios. And if somebody goes into organ failure, that's like a big predictor for post-operative mortality. So you have to kind of catch them before they go into organ failure and try to intervene before they go into organ failure. So how do we test for C. diff? The test is doing a stool study, lab test. So when we do this lab test, we do like a two-step study using an enzyme immunoassay study. So first test would be to check for glutamate dehydrogenase or GDH because that's something secreted by the bacteria. So first we would test for that, and that's kind of a very sensitive test. So if GDH is negative, that means they don't have C. diff in their stool. But if it's positive, then the next step is we check for the toxin. So then we do enzyme immunoassay for toxin A and B, and if that's positive and if the patient is symptomatic, then we kind of start treating them like somebody having a C. diff infection. Um, so the good thing is the GDH test is very sensitive and the toxin test is very specific. So in general, just this test has a very sensitivity, has a high sensitivity and high specificity. In addition, if say a patient is negative for toxins after having a positive GDH test, and they still you have a high suspicion that they might still have C. diff, like a C. diff infection, then you can do like a toxin study with a PCR, and if that comes back positive, then you still treat them like a C. diff infection. Role for flexible sigmoidoscopy or colonoscopy is very limited to diagnose C. diff infection, but it can be helpful where you are not sure if it's a C. diff colitis and you want to rule out other condition like ischemic colitis, or say if somebody come across a patient with a graft versus host reaction, or somebody with a cytomegalovirus colitis where you take a biopsy and check for the CMV inclusion bodies. That's what will help to make the diagnosis. But just to diagnose a C. diff infection, it's not that helpful. If at all we do a scope, then we see this characteristic pseudomembranes, which is like a clump of fibrin tissue with dead cells along the lining. This is very characteristic for C. diff infection, but unfortunately, you don't see in all the cases, especially people who have inflammatory bowel disease and who are immunocompromised or immunosuppressed, you won't see the pseudomembranes. And also doing a scope in these patients, you have like a higher risk of causing a perforation, so you try to avoid it whenever possible. Coming to the utility of radiology testing, X-ray and CAT scan. Here I put like a picture of an X-ray which shows like a megacolon picture. So if you see the patient has all that features of like a had a positive C. diff test and its abdomen is distended as a ileus picture, and we see that on the X-ray, then you start worrying about a megacolon and start thinking about what to do next for the patient. CAT scan, though it's again not very helpful just to diagnose C. diff infection, but it can be helpful to know some of the severity, especially if you're worried about the patient already gone into a perforation or has some areas of ischemic looking colon. It would be helpful. Infection control and isolation. So it's important that when you suspect somebody with C. diff infection, you get their testing done sooner. So that way, if there's a positive test, then you can start focusing on infection control and isolation. When the C. diff is in vegetative form inside the colon, it's susceptible to antimicrobial agents. But when it's outside, it's in a spore form, and that's very resistant. So then, in those cases, you need like hospital grade kind of cleansing and disinfectants to kill those spores. They have tried different things. They've tried like an ultraviolet rays as well. In some places they've tried it, but it's not that effective. Just regular strong disinfectants and thorough clean is what will help clean those areas. Also, from a physician standpoint, it's important that we focus on hand washing, just because the spores they are resistant or they don't die with the regular hand sanitizing alcohol. So we have to wash our hands with soap. That's the only way to get rid of those spores. And also, we have to focus on wearing the PPE gowns and gloves. So you see that once we order a testing for C. diff for a patient, the immediate thing is even before they send the specimen out, they hang like the isolation precautions for the patient outside the door, just because you don't want to know after like a day when the result comes back that it was positive and now so many people have already entered in and kind of spread the infection elsewhere. So when do we lift those isolation from the patient? So in general, like if the patient has stopped having loose stools after 48 hours of that, we can think that the patient is no longer infectious or no longer going to spread the infection. So it's kind of pretty safe at that time to take off the isolation precautions. Antibiotic stewardship program, as I said, many institutions and facilities have come up with this. There's no like fixed standard guidelines. Each place has their own guidelines, but in general, we try to. Idea of this is to limit the number of antibiotics and also limit the duration of the antibiotics, and that will help decrease the incidence of C. diff infection. Coming to the medical treatment for C. diff, previously, it used to be Flagyl as a first-line treatment, but Flagyl or metronidazole, but nowadays that's not recommended as the first-line treatment. We start off with oral vancomycin or fidaxomicin. Fidaxomicin is a macrocyclic antibiotic in the same group as erythromycin or azithromycin. And that's a much better antibiotic compared to vancomycin because there's lesser rate of recurrence with the fidaxomicin, but unfortunately it's a costly medication, so we can't directly go into that, and we start off with vancomycin for the patient. The standard dosing would be like vancomycin for somebody with non-fulminant C. diff infection. We start off with 125 milligrams 4 times a day orally, and we do it like there's no fixed duration depending like on the person's choice. We do like 10 days or 14 days. And then for the fidaxomicin, it's like 200 milligrams twice a day for 10 days. That's kind of a standard regimen. Combination therapies were tried, especially for inpatients doing like vancomycin and Flagyl. If we do that on a regular basis, we saw a lot more adverse reactions, like patients going to ileus, having a lot more nausea, vomiting kind of symptoms. But sometimes, unfortunately, when the patient go into ileus and you don't have much options, you put them on IV metronidazole, and also in those cases, you can consider doing some vancomycin enemas as well to target the vancomycin reaching the colon to help with the infection. Role of probiotics. So people thought that the main reason why the C. diff is happening is because antibiotics kills the normal microbiome, normal flora in your colon, and so that's why the C. diff bacteria gets a chance to grow and unopposed in the colon. So why not replenish the colon back with good bacteria? So there have been studies tried with 3 commonly used probiotics. One is the Lactobacillus acidophilus, Lactobacillus casei, and Saccharomyces boulardii. There are different trade names for these specific bacteria, and sometimes some of them come in combination too. I used to do that when I kind of do it in waves when I used to see patient dying with C. diff and a lot of like C. diff happening. So when I used to order antibiotics for any reason, like a big abscess or diverticulitis, I used to kind of combine probiotics. But then when after some time I stopped seeing C. diff, then I kind of weaned back on it. But studies have shown like improvement. They've shown that taking probiotics along with antibiotics does decrease the incidence of C. diff infection. So role of surgery. So it's important to know when to operate. The timing is really important because if you operate after the patient has gone into organ failure, the outcomes are not so good. So trying to know the exact time is really important. Especially, it's helpful to know patients who are at a high risk for needing surgery. So it would be like elderly patients, patients with inflammatory bowel disease, patients with other medical comorbidities, as we discussed. It's important that those patients, we follow them closely and make sure that if we start seeing any signs of them worsening, try to talk to them into surgery, or at least prepare them mentally that they might need surgery, and try to do the surgery at a proper time before they go into organ failure. So here it's important, at least for the resident standpoint, I've seen some cases where you get called for C. diff infection, you go and see, and you have this tendency to sign off early. In C. diff patients, I would say, like, even if you sign off, at least keep them on your list and keep chart checking on them, because once you sign off, the tendency for the medical team or the hospitalist team to call you back is kind of they kind of wait till the patient gets really sick or sometimes go into organ failure and then call you back. So that time it becomes a little too late and not good for the patient. So at least like it's fine, you don't have to see them daily, but at least do chart checking so that you have an idea if they're getting sick, then you can catch them at an earlier stage. So surgery part is the subtotal colectomy with endoileostomy. This has been pretty much the standard surgery. The idea was that you are doing a source control by taking away the diseased colon as much as possible, where the C. diff infection is happening and the toxins are going on. And you leave a rectal stump good enough that the patient might have like optimal function at a later stage when you reverse the ileostomy for them. The problem with this surgery is the mortality rate is pretty high because, again, as I said, the timing of the surgery really dictates the mortality. The mortality is almost close to like 40 to 50% range. So what are the predictors of mortality? Again, the same thing: elderly age, medical comorbidities, immunosuppression, and patients have already gone into organ failure. The unfortunate part is we don't have any set standard criteria when to take the patient for surgery. That's our biggest problem. I remember during residency, we were talking about how about we keep like white cell count greater than 20 as a criteria, but that kind of criteria just with a number is not good because you have to take the overall picture. You have to take see how the patient overall is doing, how the other organs are performing, and is if he's showing any improvement. So just going by one parameter is not like a good enough criteria for subjecting someone to a big surgery. At that time, there was some talk that say if somebody goes has a white cell count over 20, should that be a trigger to just make it as a surgery consult again? Keeping such kind of like criteria might not really help. So we leave it up to the vision of the infectious disease and the hospitalist team to decide when they want to call the surgical consult. The other good alternative for a big subtotal colectomy is doing like laparoscopic diverting loop ileostomy and antegrade colonic lavage. So this is the surgery which I commonly do for patients when they call me for C. diff infection, and I've seen good results with this surgery. So this technique was first published in 2011. It was a study done in Pennsylvania, and there they did like a prospective trial on 42 patients where they did this diverting loop ileostomy and a lavage, and they found that the mortality rate, which was with a historically compared controls, was 50%. With this approach, they brought down the mortality rate to 19%, and also the morbidity rate was really low with this, and a good number of patients were able to get the ileostomy reversed, and they had a better lifestyle following the surgery with the ileostomy reversed. So then I saw like there were a lot more other studies done or published checking this technique. Especially, we did not have any good randomized controlled trials or like proper prospective trials, but all the other studies were like NISQ based or data-based trials, and all these database trials, what they found out is that the mortality rate was pretty much the same, but definitely the morbidity rate was really good. Now, the biggest problem with this approach or this kind of study is the timing. Again, the timing is very important when you decide to do a surgery for the patient, and whatever kind of surgery you do. When did you go in for the surgery? If you waited too long and went when the colon was almost about to die, then probably our patient was already in organ failure. It might have been too late. So then with such a big difference where we say the morbidity is really good for that approach, why is this approach not seen that often? Why don't we hear that much about this this diverting loop ileostomy with lavage? I think problem is lack of technical knowledge. So in my fellowship, I did not, or my residency, I did not see this technique being done. But then once I trained, I was able to find out with my colleagues, and then I started doing it. So I think problem is the lack of the technical knowledge, and also patient selection is important. I've been repeatedly saying the timing is very important when you do this surgery. And then, so when you get a consult for a patient with C. diff and you think that he might be going that route, it's important to start preparing the patient and the patient's family. Once in a while, you'll come across some patient who would say that they would rather die than have a bag. So then you know that that this patient probably you should not force them into surgery, and it's better that you get their opinion while they're in like a state of mind to convey their opinion, rather than when they get really sick and intubated and then you subject them for surgery. So it's important that you start preparing them so that way when they start getting more worse, then it doesn't come as a surprise for them, and you too can be prepared with your time and your schedule to see that most likely he might end up needing a surgery. So the steps for this surgery. So some of the things which I learned from my colleagues, and I have been doing it kind of, I would say average, I would do maybe 1 to 2 of this surgery in a year. So far since I joined CH, I did 3 of them in Emmanuel Hospital, and all of them did really well. So first thing, like you position the patient in a lithotomy position, like how you do for a left colon surgery. What's helpful is putting this fecal management system in your rectum, because you're doing a big 2-gallon kind of colonic lavage, so you should have a good way to collect the stool. And then the other end of the tube, you just put it in a kick bucket with a plastic bag. And then other important thing is before the surgery, mark the ostomy site. It's very important that you do like place the ostomy at a good site. So in my talk about ostomy a couple of years back, I said that having a bad ostomy or badly matured ostomy at a good ostomy site is much better than having a very good matured ostomy at a bad site. Meaning to say that if you put it at a skin fold or a place where the bag will not stick, no matter how good of a maturation you have done, how good of ostomy you created, that the patient's life is going to be miserable. So make it a point to mark the ostomy site pre-op. Even if the patient is intubated and cannot sit up, at least like make the bed kind of prop up the head end of the bed and see how the skin folds are, and do a marking. I keep telling that to all the residents, but I never see a patient being marked beforehand. So maybe one day that will happen. It's important. You mark it, and then I kind of come and check and mark it, and then you'll know if it was a good position or not. Okay. So that's important. Then the next one, as I said, position the patient with lithotomy, put the fecal management system. And I do like a standard 3-port laparoscopic diverting loop ileostomy. We keep this surgery like simple. We just do an umbilical port, 2 ports on the left side, identify the ileocolic junction. But before that, you also have a look at the colon. If you start seeing like areas of on the serosa, which looks like it's not that healthy and gonna have an imminent perforation, then you can't do this ileostomy. You just have to do a subtotal colectomy. But then if the colon from outside on inspection from the serosal side looks good, then bring out a loop ileostomy. And when you bring the loop ileostomy, you in these cases, putting in a red rubber catheter as ostomy bridge will help, and I'll tell you why. Then, so here you have your ileostomy out here, red rubber catheter, you close the wounds. If you want, you can put a skin glue. Now, the next step is you cut open the ostomy, and on the mucous fistula end, you put a Foley catheter in. Okay, you put a Foley catheter in, and then you confirm that the Foley catheter is in the cecum before you inflate the balloon. The way to confirm that is get an EGD scope, or even a pediatric colonoscope is fine. I prefer EGD scope because it's like a smaller diameter, and then you put it through the mucous fistula, and then confirm that the Foley catheter balloon is in the cecum. Then you inflate the balloon. So once you have got that confirmation, sometimes it might not, or you might struggle putting the catheter in. So with the guidance of the EGD scope, you can pass the catheter along. And then after that, you get like a cysto tubing, because you really don't want to use an infusion tubing to push 2 gallons in. It might take 2-3 hours to go through. So get like a big size cysto tubing. Get one of those 3-liter bags which they use for cystoscopy. Cut the bag from the back end where it's like close to the hooking part of the bag. Empty that bag and fill that with Go Lightly. So we use 2 gallons of Go Lightly, so you'll have to do it like 3 times, 3 liters, and 2 liters to finish the 2 gallons of Go Lightly. And then you put this, connect the Foley catheter to this cysto tubing. Make sure you have some at least couple of suction tubing nearby, because there's going to be some leakage. To capture that, or maybe make like a little well with some towels around it so that you don't have a big spillage. And but if your balloon is sitting nicely in the cecum, you have got the confirmation that leakage should not be that much. And then you open it, and then start like counting some numbers in your mind till you start seeing like the stool pouring out through the FMS. So it's kind of a sight. You see like a dam taking open. You'll see like once it starts, then it's like a big gush. And the idea of doing this lavage is you want to flush out all the toxins and the bacteria from the colon. Okay. So people have mentioned that little warm go lightly. Sometimes it becomes difficult to get like a warm one, but at least don't use like a super cold cold solution to do this. So then after doing like 2 of those bags, filling it up, then the third bag, which is going to be 2 liters, in that I add like 500 milligrams of vancomycin just to do like a little vancomycin at the last part. And okay. So, and then next step is once you've finished the irrigation, tie off this Foley catheter to the ileostomy bridge. This is where this ileostomy bridge is helpful because then you can keep the Foley catheter secured. You do not want that inflated balloon to kind of the colon to start peristalsing that inflated balloon and suck up this catheter in. It has not happened, but theoretically possible. It's nice to just kind of keep that secure in place. And you put like a ostomy bag on top of it, keep this catheter buried in the bag. And then in the floor, you continue doing the antigrade vancomycin enemas. You ask the pharmacy to mix like 500, I use 500 milligrams of vancomycin with 1 liter of saline. And then you tell the nurse exactly like the same contraption with the cystoscopy tubing and the bag, pour it in the bag and connect it to this one, and keep the FMS bag in the rectum. So that way it doesn't cause like a big mess on the bed. And keep doing that every 6 hourly for at least 3-4 days, and before you start cutting back on that. The advantage of having the ileostomy in place is once the patient starts getting better, you can even consider doing a stool transplant through that same tube. So that way you have kind of replenished the colon with the normal microbiome, the colonic microbiome. And then depending on how the patient recovers from the surgery, then you can plan for a ileostomy takedown surgery. It's a typical ileostomy resection reversal surgery. You can do anytime from 6 weeks onwards. One important thing I kind of do here is avoid any prophylactic antibiotic for this kind of case, because antibiotics is what started it in the first place, and I don't want to give like a typical any kind of pre-bowel surgery antibiotic of Ansef and Flagyl and then put this patient again at a risk of developing C. diff infection, because that's what started the surgery in the first place. Coming to definitions for recurrent and refractory C. diff infection. So recurrent is if somebody has like a positive stool test within 8 weeks of completion of their C. diff infection treatment. And refractory is when they never, like they finish their standard course of treatment with oral vancomycin or fidaxomicin, and still they are having symptoms and they never got better. Okay, so the recurrent infection rate ranges, that's a big range from 8 to 50 or almost 60%. And again, the same risk factors for recurrent infection too, like old age and use of PPI. But very important is if they had antibiotics repeated again. I've seen like patients with who keep getting recurrent urinary tract infections are the one very notorious. They get very sick and symptomatic with UTI that they go back on getting antibiotics, and then antibiotics will make them have the C. diff infection again. And so when you deal with recurrence, the idea is do not do the same kind of antibiotic again. Say if you give vancomycin to them, we would not recommend repeating the vancomycin, try fidaxomicin if possible. It's helpful. And in some cases where it becomes an issue, where they are in refractory or recurrent C. diff infection keeps happening, you can talk about doing like a tapered dose of vancomycin, taper it over 6 weeks, and also do like a pulse dose where you can keep giving like a dose of oral vancomycin every 2 or 3 days, and keep going for under like 6 to 8 weeks, and see if that helps them. So next important part of this talk is the FMT, or fecal microbiota transplant or a stool transplant. I'm sure everybody has heard about it, but if I ask like, do you know the exact details how it's done? Not many people would know. I took interest in Sioux City, so I kind of went into more details on this. So who are the candidates for that? So if somebody had like 3 infections, like 3 recurrence, or if they had 2 severe kind of C. diff infection which needed like hospitalization, or if they are actually going through an active severe infection, still not gone into organ failure, and they're not responding to the antibiotics given while in the hospital, then you can consider doing a transplant for them. It's contraindicated, of course, for patient on immunosuppression and patient who have liver failure, who just had some bone marrow transplant or advanced HIV or AIDS. The way to administer is we could do like a NG tube administration. It comes in capsule form, enema forms, but the most proper or reliable way of doing that was through a colonoscopy, injected directly into the cecum, and that had the best success rate. So in the past, nowadays, I don't think many people do that. In the past, we used to ask patient or places which did the stool transplant, they used to ask patient to get your friend or relative who can be a stool donor. And then when they get those people, then you have to do all the testing on the donor, and the testing is same kind of test what you do for when you take a blood donation from them. And at the same time, in addition, we have to do all the stool tests for them. So, and then the people who had like recent antibiotics within the last 3 months, who had like international travel to a place with GI issues or high GI infection kind of places, or people with IBS, chronic constipation, they should not be the donors. So once they went through the screening test and they kind of passed all the screening tests, both the blood and the stool test. Then the way it was done was you asked them to bring their fresh poop. In fact, we asked them to take little stool softeners and eat little better healthy like fiber diet or something the day before, and then bring their fresh poop. The center used to then take like a 50 grams of the stool and then blend it with another 200 ml of saline. The important thing about blending is don't blend it too vigorously, just little pulse blending, because if you put too much air in it, it might kill the organism or cause some changes. And then you sieve it, and then you collect like 200 ml of that mixture, which is like sieve. Then you do a colonoscopy and you push it into the cecum. Okay, and so that's how it was. But okay, so this transplant really worked well for people with recurrent or refractory CDF infection, especially the elderly, the immunocompromised, and the critically ill patients with inflammatory bowel disease. The predictor for failure was if they did not have a good prep. So yeah, the recipient does a bowel prep so that he kind of flushes out his colon. Also in the recipient, after doing this transplant or before doing it, we used to give like a couple doses of Imodium to slow down the transit and give longer time for the transplanted stool to stay in. Okay, but if this patient had no worries, we'll do that. Okay, so the biggest problem for creating this program, I had like a meeting for more than a year, multiple meetings with the hospital people. The biggest problem was who's going to pay for the donor testing, because the donor is not going to, I mean, you can imagine all the blood tests and the stool tests, that's like a big list of tests. That test easily would come to like they say $500, I would say maybe like $1,000. Who's going to pay for it? Ideally, the recipient insurance should cover it, but trying to make the insurance company agree to that and pay, it's a big hassle. So that was a big problem. And then the other problem was as this was getting more popular, there were more and more stool tests being added, because once in a while, someplace some rare disease was found, so they used to keep adding more tests. And then to coordinate this, like it's like a big thing, getting a family friend, doing all the testing, and then the liability issue. So there was like some place where there was a case where a person got from an obese person's stool, and the person got obesity. So then there was the issue. Then somebody started having symptoms of IBS, and they thought the donor had like IBS, and then some other autoimmune condition. So it's always an issue. Then you can't like anyone can sue you at any time, and then you won't be able to defend, because it's not that that well studied. So when there's like an opportunity, somebody comes up with a business idea, right? There's a need and opportunity. So this Open Biome company, it was based in Boston, and they came up with this idea of giving like a frozen stool, which you just have to thaw for like 4 to 8 hours, and then it's ready to just put it as a transplant. So they had, and because it's a Boston, it's a university place, there were a lot of students who were willing to just go get screened and keep giving their stool. So they used to had to poop, like say for a month, and then guess how much they got for a month of pooping. This was like 10 years or 12 years back kind of thing. So they used to get paid like $1,200 or $1,500 at that time for giving their poop every day for a month. But for that, they had to there was a big kind of a screening test that they had to go through. And should not be like I don't know what heavy drinking means, but they are no smoking, no drug use, no recent travel, no tattoos, no hospitalization, no antibiotics, and then all the like blood screening, the stool screening test, as I said. So, and once they do this donation, their stool was all quarantined for 60 days, and they were observed for 60 days to make sure that they are all good, nothing bad, and before they let the stool be released for use. So this used to work out good. I probably I would have done close to like 40 stool transplants in the 7 years there, and patients with recurrent refractory, they really showed. And they really got better. There was one patient who, or two patients where or maybe three patients. So one of them had like an antibiotic impregnated implant in the joint, and that's why, like, in spite of this, because there's like a constant slow dose antibiotic coming there with an infected joint. So that did not work. She again got symptomatic. There was one patient with recurrent urinary tract infection who unfortunately had to keep taking antibiotics, and then again they developed recurrent, because the risk of getting C. diff infection again is same after the transplant. It's not like you're going to change that risk. If they take antibiotics again, they're going to get it. And then there was one patient who used to work in my office reception, and she was a little hesitant to discuss with me, young patient. So she used to come through my nurse, and we did the testing, and she was positive for C. diff. Did the deficit of edoximine a couple times, and still was positive. And I kept on asking through my nurse, did she take antibiotic? Does she take antibiotics? She said no, no, no. And then finally we decided we'll do a stool transplant. And when I did the stool transplant to colonoscopy, and when I was doing her medication reconciliation at the end, I found out that she used to use clindamycin cream on her face for acne. So for antibiotics, it's not that just like taking orally is what matters. Even like any kind of form you put, like dermal, or if you have it in a joint spacer, anyway the antibiotic enters your system, you're prone to get the C. diff. So I wish I'd known that before. Probably I saved a stool transplant for her. But we saw the problem, we stopped the antibiotic, and the stool transplant also helped us. So it's important to kind of get a good history. So some lesson I learned that day. The unfortunate part is this company closed last year, late last year, because they did a good job. A lot of hospitals around, like I know UNMC used to use this company because trying to, as I said, the big hassle of getting some donor and going through all the screening was like a big painful process. And they closed it because the FDA, when they allowed them to use it, it was under experimental kind of a license, and they never really completely made it like a full license. Also the COVID hit the company really bad. With COVID, they had to stop all the shipping. They were not sure like how it's going to go. So then they had to shut down. And I feel bad because this really was a lifesaver. I always used to have a stock. We kind of buy it in bulk, so that way we save on shipping. And then we used to keep it in a freezer at minus 20 degrees. And it was a lifesaver for some patients. So now we have like two products in the market. One is Rebiota, which they're saying is again suspension of the microbiomes from screen human donor. I don't know how exactly they get it, but it comes in a 150 ml pack. The biggest problem with this is they just do it as an enema through like an enema tube. So now with my experience, what I've seen, like, you have to push it in the cecum for it to work well. If you don't read the cecum, then it doesn't work well. I don't know how this company is marketing. In every GI meeting you go to, or colorectal, these people have their stall and they keep telling that their product is so good. So it doesn't make logical sense to me that you just put like 150 ml of this microbiome in your rectum and you hope that it's gonna work so good and all the way to the cecum to kind of replenish your cecum. So it's there in the market. And the other one, and the interesting, they say the enemas, you cannot do it yourself. You have to come to healthcare, like in the office, and get it done or something. So then the next one is the microbiome in a spore form. Okay, that company name is like Woust, and this is actually given to prevent recurrence. So even the other one was not for active treatment; it was more for to prevent the recurrence. So then the microbiome's spores they come in like a capsule form. I don't know how this is different from a probiotic, but you just take a capsule and hope that it works. So coming to the last part is the adjunctive agent. So people, one big thing is when somebody comes in with diarrhea, the reflex of a lot of people is to, okay, start taking some Imodium, start taking some antidiarrheal medication. And that's one thing which can push someone, especially in a C. diff infection, to a fulminant colitis where they're not able to clear up the toxins. And the reason why the body or somebody has diarrhea is it's kind of a body's natural defense mechanism. You have infection, it's trying to flush out the infection, trying to flush out the toxin. So now by giving an antidiarrheal medication, you're stopping the body from doing that, and then you can get more sick. So when somebody comes with diarrhea and have a suspicion, then I kind of do their testing of the stool first to rule out C. diff infection before I start them on any anti-motility agent. So that's important. So again, that's important to know, and don't start it because sometimes people go to urgent care, they're given that, and then they come in really sick. I've seen that happening. So what do you do for the diarrhea? Because patient they kind of they want something done for the diarrhea, they want that stopped. So in those cases, you can consider the cholestyramine or the Questran or the cholestyramine. These are the basically they are bile acid sequestrant, but they do the same kind of they bind to the toxins and kind of minimize the effect of toxins, and in that way they help with the diarrhea. The other medication is rifaximin or Xifaxan. Again, that's a very pricey medication. It's given in patients with IBS with diarrhea or people with bacterial overgrowth. We do that, so that medication can be tried. Tigeslin is other antibiotic. It used to be used a lot. I'm not seeing the ID people using that so much now. And that's a medication called Alina or nitroniclazide, which is given for it's anti-parasitic medication, also given for people with Campylobacter infection, but it can help with C. diff infection as well. So to summarize, C. diff can be life-threatening, so don't take it easy. Don't sign off on the patients very early. Just kind of keep an eye on them, see peripherally like what happens to their white cell count, what their vitals are doing before you completely take them off the list. And always remember the diverting loop ileostomy with antegrade lavage as an option. Very good surgery with less morbidity. You don't have to deal with an open wound. You don't have to deal with patients losing most of their colon and then getting a ileorectal anastomosis. And then remember about the stool transplant, which probably it's kind of sounds a little historical now, but maybe there'll be more research. At one time when stool transplant was getting popular for C. diff, there were a lot of other stool studies being done. There were studies being done to see if that can help with the obesity treatment, if that can be a treatment for the inflammatory bowel disease, if that can be treatment for some mental health. So they thought everything is associated with the microbiome in the colon, but I don't see that many studies anymore. So that's it. Yeah.
Thanks, Dr. Subhas. That was a really good talk. I had a couple of comments, for the residents, on these patients, the window to intervene is small. It's important to have your finger on the pulse because people go down pretty quickly. And you have to recognize when something has changed drastically, because it's okay to say 24 to 48 hours of maximal medical therapy, you give it a chance to act. But if you don't see them getting better, that's probably the time to pull the trigger. You don't have a big window. People can deteriorate pretty quick. Related question to, diverting loop ileostomy with antegrade lavage started catching speed towards the end of my residency. We did it at times. But like you said, the timing is sort of critical in something that's already a little bit of a gray area as to when to intervene, like which intervention to pick can become complicated because, colectomy is for source control. Now, that's a little bit, backwards sometimes when the patient's getting really sick. If you're not taking out that and giving a chance to antibiotics to do more work, sometimes you may end up still in the operating room again, trying to take that colon out, now in a worse place. So, I think that's the dilemma.
No, yeah, I agree. And thankfully, the cases where I did the diverting loop ileostomy, I did not have to go back to take the colon. So I feel like if the lavage is done really well and we continue following with the vancomycin and also the patient selection, like once you start knowing that they are going there and their creatinine is creeping up, they're going into ileus, the belly is getting bigger, don't wait till like another day or so. Just that would be maybe that's a difference.
Thank you. Yes, I agree. A very interesting and organized presentation of what can be a very messy subject. But when you were discussing this antegrade lavage and the patient selection as mentioned, you talked to being so you moderately ill patients and before they get too sick, so on and so forth. I wonder, has anybody looked at whether there's value to a go lightly lavage orally prior to reaching a point of severe illness, somewhere between mild and moderate, selecting patients and considering maybe mechanical cleanse of the colon to see if that can prevent progression of the disease. You know, if that's ever been looked at or tried.
I'm I did not see any study like that. I mean, that's a good thought, but again, the timing would matter, and giving like a go lightly where you don't have things under control might not be that great of an idea, especially when they're reaching that stage where they're getting more sick. But again, on the same note, when we talk about doing a stool transplant for them, if they're not showing response in 2 days, we do a prep and then do a stool transplant. So yeah, I've never done go lightly just for the sake of kind of getting rid of the toxins and bacteria, but it's a good thought.
Sounds like a study that could be.
Yeah, the unfortunate part is we don't see that many patients. That, as I said, like 1 or 2 a year is not like good enough to come with any meaningful results.
Yeah.
Any other questions for Dr. Subhas? I just have one, quick question. When you're doing the subtotal colectomy, do you ever have issues with, C. diff in the rectal stump?
Yeah, so that's a good one. So if I do a subtotal colectomy with the rectal stump, I try to leave little longer stump unless I see that area of the rectum is very, very inflamed, and then I try to go lower. And then what will help is if you have doubt that the stump will burst open, which can happen quite often if the rectum is inflamed, try to oversew the stump line, and also putting like a Malin-Cord catheter in the anus, because sometimes people might have little like a sphincter spasm or tight anus, and that will prevent all the mucus which the rectum will still secrete because of it being inflamed from kind of escaping from the anus, and then they might like burst open through the staple line, which at this stage is the weak spot in the rectum, and then they can have like an infection and little prolonged course. So putting a Malin-Cord catheter, oversewing the rectal stump, and kind of deciding where to transect. Whenever possible, I try to leave a longer rectal stump. And also by putting a Malin-Cord catheter, if you're really worried, you can do some gentle like vancomycin enemas as well, like not overfilling it, but little gentle vancomycin to clear up the C. diff from the rectum.
Great. Well, thank you for an excellent presentation. Very timely, especially for the general and acute care surgeons. I just have a couple brief announcements and reminders. So again, please, for the faculty and residents, complete your evaluations, and then also, EPAs and simples. We brought back the leaderboard, so we'll continue to have those updates for everyone as well. You can get raffle tickets and the prizes. So hopefully next week we'll see the results of that. Interviews for faculty and for residents are coming up starting in November, December, and then we have one date in January. So please sign up if you haven't already. It's a great opportunity to kind of pick your colleagues, pick the residents that you're going to work with. It's always exciting to, I think, talk to the medical students who are going into surgery. They're very passionate. It's always, fascinating. I always learn very interesting things speaking with them. We have Journal Club tonight at Saffron, so I hope that everyone will please be able to join us with the cardiac surgery team. Faculty and residents, you may have also received an email from the SCENT trial group. This is kind of one of these numbered trials and surgeries. This is a wellness surgery. They had previously, planned to do kind of a, DEI type survey, but they pivoted to wellness. It's totally uncoupled from, any accreditation activities. This is purely designed, to study, resident and faculty wellness, and to provide the programs with some data. That being said, the ACGME does expect a 70% response rate, which is, separately a kind of a contentious issue. But if you have received that email, I don't know who exactly it's being sent to. Please complete it. I did it. It only takes about 5 minutes or less. So thanks again, everyone.
Yes.